for joining a bit late because I was held up in the parallel inauguration program that was going on.
Must be, yes.
Sorry, sir.
I'm
and
good. How are you?
Good, sir. Good, sir. Thank you, sir, for joining, and thank you, Professor Gaidane. Uh, Sir, actually, there was a parallel inauguration program from 9 to 10, and it was
Okay.
about to finish. And being a president, I had to be there. So apologies for
No, no, no
joining.
problem.
Yeah. Sir, thank you so much for joining this important initiative. And so I just wanted to brief you initially and all the participants that this IAPSM Young Leadership Program that we developed over a period of time, and with the intent to provide a platform to our younger colleagues to organize, facilitate, and engage in discourse related to various public health issues, but also help them to showcase and demonstrate their talent and competence, and particularly in the context of creating leadership. So the whole idea is that this whole program is organized by the team of young professionals of IAPSM, and they are all members of IAPSM, but postgraduate students, junior faculty members, they come together, they design the program, and the whole program is addressed to the felt needs of the younger members of the IAPSM. And so the Indian Association of Preventive Social Medicine is an association of the MD Community Medicine, MD SPM candidates across the country. And they are working mostly in the departments of community medicine in medical colleges, but also working in the health services, NGO sector, UN organizations, and have been playing an important role in advancing the public health agenda of the country. We also publish Indian Journal of Community Medicine every year. We organize national conference also, and we very closely work with Niti Aayog, Ministry of Health and Family Welfare, and state governments, sir, on various public health related initiatives. Notably, in the context of COVID-19, we very closely supported several initiatives of the Government of India, both at the national and state level. And as a part of this association, sir, this is a group of IAPSM young members. Uh, 800 participants have enrolled for this particular conclave, and the program is designed in a such a way to facilitate their leadership skills, competence, and create future public health leaders and champions in the country. And so, as a part of this, what we do is that we organize. This is the second conclave, sir. Last year, we had organized the first conclave at the Datta Mega Institute of Medical Sciences in Savangi. It's also in the Wardha district only. And Professor Abhay Gaidane, who is co-chair with me, along with Professor Zahir Kazi and Professor Sonali Chaudhary at their institute, had organized this particular conclave. This time, this is being hosted by MGIMS Sevagram. It's one of the very premier institutes of the country, and where the Bapuji has lived, and Dr. Sushila Nair was the founding person for this institution. Uh, so, and these young colleagues who would be joining, basically, sir, initially would listen to your journey into the public health, and how actually your contributions and your exemplary contributions, rather, I would say, in the context of public health, and what are the lessons that learned, and what would be your advice to the young colleagues who are now either have just ventured or would be venturing their professional career in the public health. So that's the context, sir. But for the benefit of the young participants, I would like to introduce you, sir. Uh, I'm happy that we have a pleasure of having Shri JVR Prasada Raoji, who is a formal special envoy to the UN Secretary General and former Health Secretary Government of India. But on a personal note, I would like to mention that Sir has been very closely associated with the Public Health Foundation of India. He is on the board of the PHFI, and also the we have him as part of Indian Institute of Public Health Delhi as the chair of our advisory committee also. And therefore, in both capacities of him being on the board and associated with IFA Delhi, I have a very close interaction with sir, and sir, we always see you as a distinguished role model for us who has ventured civil services into the public health. But as a formal introduction is concerned, he worked as a former Health Secretary, Government of India, and has retired from the government in 2004. But even these last 16, 17 years, he has been very actively contributing to the field of public health. He has served as a director of National AIDS Control Organization, additional secretary in the Ministry of Health and Welfare as a part of his civil servant career. And then he has led a very unprecedented response with the multi-stakeholder involvement in the context of AIDS epidemic. 2002 to 2004, he served as a secretary in the Ministry of Health and Family Welfare, Government of India, as I mentioned, and was very instrumental in bringing the national health policy and the national AIDS control policy in 2002. And he has also led important national disease control programs like tuberculosis, malaria, and leprosy elimination, are very critical and important public health programs in the country. Then he was invited to join as a regional director of UNAIDS, the joint UN program for control of the AIDS in December 2004. He moved to Bangkok and headed the Asia Pacific regional office and worked there for almost 5 years, up to 2009 or so. Then during these 5 years, he led the UN, United Nations response to the AIDS in Asia Pacific countries using his very extensive experience from the India's national program and which was one of the largest programs. He also served as a member secretary of two independent commissions on AIDS for Asia and Pacific to critically look into the dynamics of the epidemic and its socio-economic implications to the people of this region. He initiated several measures at decentralization of work continues to countries in the some resource mobilization for the program. He was a very strong advocate of promoting regional civil society organizations as a of the key populations who are vulnerable to the HIV epidemic. Then, after return from Bangkok, Shri Prasada Raoji was appointed as a special envoy on AIDS for Asia Pacific region by the Secretary General of United Nations, that time Honorable Ban Ki-moon. He interacted very closely with several political leaders across the countries and the prime ministers and presidents of the countries for prioritizing the AIDS control as a national plan and strategies. He spearheaded several discussions on inclusion of AIDS elimination in the Sustainable Development Goals for 2030, and which was subsequently was adopted and then it's part of the declarations also. He also functioned as a Commissioner Secretary of Global Commission on HIV and Law initiated by the UNDP. Currently, he is a member of the ICMR Task Force also on COVID-19 in India and member of the Global Advisory Board of the State Government of West Bengal on COVID-19. He wrote extensively on public health issues with special emphasis on control of communicable diseases, and he chaired several committees in the government also in the context of governance of several programs. And recently, he has authored a book titled Celebrating Small Victories, tracing his journey through the 2 decades of HIV and AIDS response in India and the Asia Pacific region globally. Prasada Raoji holds a postgraduate degree in nuclear physics from Andhra University of Visakhapatnam. He joined the Indian Administrative Services way back in 1967. Several of us might not have born by that time and served an important assignments in the districts and the secretariat in the West Bengal before joining the government of India. I just wanted to show you, this is the book actually. I wanted to, this is the book that he has written celebrating small victories. And I will request organizers to share with you the book review of this particular book, which has been recently published in our Indian Journal of Public Health, which all you read. But I would say that I have read this book between the lines, and this is the must-read book for all the young public health professionals. That would be my strong recommendations for all of you. With that remark, sir, I would request you to first, the way we structure program is to you share your experience, your journey, and please feel free, sir, because this is a very, we wanted to say formal, come informal interaction with our young professionals. And then, sir, after at the end, we will open up for discussion also, and Professor Gaidhani would lead the moderate the discussion with the members. So over to you, sir.
Thank you, Dr. Jodpe. Thank you, Dr. Gadani, and the organizers. And I must thank the IAPSM, Youth Leadership Conclave organizers, for this great privilege that you have given me to address young public health aspirants, because nothing excites me more than talking to the young people who are looking for a career in public health. I would try to trace my journey through this last so many years of public health response in India, and also I will briefly touch on the Asia Pacific and the global situation also in the process. As Dr. Jodpes mentioned, I am a nuclear physicist by education and a practicing public health professional in work. I don't know how this combination works, but that I have tried to, I don't say they are contradictory to each other, but they in fact reinforce each other in a number of ways. Because as a physicist, I have always been guided by evidence, strong evidence for anything, and having a scientific temperament in addressing social problems also. So that way I try to blend the two into a good combination in my life and also in my career. I mean, that's how I put it. But for a civil servant like me, who joined the service, as many of you must be knowing, we are supposed to move from one place to another within a period of 3 years on transfer, and in the process acquire knowledge about the work that you do. So at the end, you always end up as a glorified generalist, knowing a bit of everything and not too much of anything. So that is unfortunately the way the services are structured. But I would say that to the credit of many of my colleagues, in this roller coaster career that we have, the many who tend to specialize or develop special aptitude for work of different nature. We find there are good economists who have come out of it, good political scientists who become ministers today, you find, good social scientists. So that way there are many people who have been able to specialize in a number of areas and excel. In my case, I didn't have any specialized degree in public health. And because in the 70s, when I was recruited, there was nothing like that. And public health was not a career that was chosen by young civil servants. But for me, I think certain situations which I was put in exposed me to the importance of public health and also social sciences in general. I think today we are celebrating 50 years of Bangladesh independence. I think our Prime Minister is going to Dhaka. So I'm just remembering those days. That was my first exposure to a major natural disaster and a major public health program. Because at the time I was posted as additional district magistrate in one of the border districts of West Bengal, bordering the then East Pakistan. And then suddenly the war erupted. And even before the war, within a period of about 2 weeks, 1 million refugees have crossed the border and came into my district. And the population of the district was about just about 15 lakhs. So imagine 10 lakhs of people getting added to the district population over a period of 2 to 3 weeks. So that has completely upstaged everyone. It was like a complete chaotic situation, but in that we could provide shelter to them. We could provide health facilities. We looked after them for about 10 months or so, 10 months to 1 year. Then after the war, we had to repatriate them, all of them, most of them, in fact, I would say, back to the then liberated Bangladesh. So that is one experience which I still cherish, because for the first time I was exposed to the degree of human misery that an incident like this can cause. And I don't think I have seen such human misery in my life any time after that, except probably during HIV, that on a very small scale, but a large scale. But throughout India, some or the other people were not very aware of it, mainly because it was only the border states like West Bengal, Assam, and the northeastern states which were impacted by the tragedy, not so much the rest of India. So it was not properly documented, I would say. But that was how I started my journey in health and health-related social science areas. Then the next was, at the time I was just 26-year-old, and we didn't have the type of resources that we have today to tackle issues at the district level. So I thought I just want to flag that initially. The second opportunity which I got again to work in public health was, of course, in the health ministry. That happened maybe 20 years later on in 1997 when I was looking for a posting in Government of India. I was in the state government of West Bengal. I was a resident commissioner in Delhi. Then I got this offer of joining the ministry as additional secretary public health and also to head the National AIDS Control Program as the project director of NACO, the National AIDS Control Organization. I knew nothing about HIV at the time, no idea, except that AIDS is something which is a big problem, is already there for some time. So I was just thrown into it, into a strong current. And when I joined the ministry, the situation was like this. Imagine 1997, we did not have a national health policy. The last health policy that was announced was in 1983, which is completely out of date by the time. There is no AIDS control policy. And if you look at the political leadership, I will come to the importance of political leadership later during my talk. It is one of the most unstable type of governments we had. Because those of you who are senior enough can recall, the Congress government went off the office, the BJP government became unstable, they were just there for 13 days. Then there was a third front government which came into power, and they had two prime ministers, Mr. Devagowda and Mr. I.K. Gujral, in quick succession. And I joined during that period. So you can imagine the type of political support you can expect for a program like HIV/AIDS. So when I joined the health ministry in Nirman Bhavan, I could hardly locate anybody whom I can call as a member of the NACO team. There were just a handful of them. So, and then addressing a problem so huge, because we know that it is a serious problem, but the country and the political leadership was still in a state of denial. Because we all thought, and even in international conferences, our political leaders would say that, look, AIDS is not a big problem in India. And because we are a moralistic society, and it is not going to happen to us. That was the time when India was passing through the peak of the epidemic in 1997. Later on, we realized that. But we are merely reporting 90,000 cases per year to the parliament, to the people at large. So my first task was to see how we can generate evidence to sensitize the political leadership, to see that, yes, this is a huge problem, please take it seriously and put it on priority. So slowly but surely, we have developed the surveillance systems. It took me 1 year to bring all the state governments on board. In fact, at the time, Dr. Subhash Salunke was the Director of Health Services in Maharashtra. He was one of the first people I met during my visit to Mumbai. And he said, unless all the states do together, the importance of such a surveillance will be lost. So with a lot of effort, we did the sentinel surveillance. And we found, based on the estimations that we made with the help of local experts and also some experts from outside, that India indeed has something like 3 million infections in 1997-98. And from 90,000 to 3 million, how do we make people understand this? How do we make the political leaders understand this? But luckily for us, there was already a change of government, and the NDA government, the first NDA government took charge. I think Mr. Atal Bihari Vajpayee ji was the prime minister. So we thought, unless he intervenes and then brings it to the notice of the people, it's not going to make a difference. So I and the junior minister who was in charge, we went to him. He gave us time, and in 15 minutes, I explained to him our survey, our sentinel survey, and what has come out of it. And I said, sir, unless we share this information with the people, unless we own this huge problem, our response will not be okay. But he was such a statesman. He was not just a normal political leader. So he understood the seriousness of the problem. And immediately he said, yes, we must tell the people. And I'm going to do it. So he volunteered, in fact. So on one of the World AIDS Day, normally World AIDS Day is celebrated on the 1st of December, observed rather. He addressed parliamentarians and he said, it is a huge problem we have. We have 3 million infections. We need to do all this that need to be done. We have to educate our young people. All the right messages he has given in a 35 to 40 minutes of speech. And I think that is the day which I call a game changer. And it completely upset the whole balance. And then the press was very wild. I said, look, why did you conceal it so long? And some people said, no, you are exaggerating it because you wanted more money from the World Bank, etc. This was the controversy that is going on. But finally, the country came out of the denial mode and we had this program. Why I narrated this incident is, in public health, one thing we must understand, that leadership matters a lot. Because as professionals, as whether we are bureaucrats or technocrats or scientists, we feel that we are the ones who have to run the program. And the political leaders sometimes unnecessarily intervene and, they delay things and they have wrong priorities and all that. But I tell you, unless they are brought on board, unless they lead the response, we cannot take it beyond a particular point, because they are the ones who have the voice of the people. They listen to the people and they can motivate the people. And without people's participation, public health programs will not succeed. So that is one lesson I learned, and I tried to apply it through my career. So whenever there was something, I always used to go to the political leader and say that you need to come and be on board. So that happened. But another aspect that helped me in that is knowing the communities who are at the center of any epidemic, any public health issue. Because generally you will find that when there is a problem, whether it is AIDS or TB or even the recent COVID-19, it is the vulnerable populations, the poor and the vulnerable populations, who are disproportionately impacted by the problem. Because whether it is an epidemic or something else, whether it is a flood or a natural disaster, anything. A public health problem always impacts the poor and vulnerable much more than other people. So unless we know how they live, what are their problems, and how we can reach services to them, the implementation will always suffer. You may have an excellent policy, but unless you know the implementation problems, the bottlenecks that can happen in the process, you will not be able to reach the benefits. In my case, within a few months after my joining in ACO, I met some sections of the population which many of you young people, you would not have met even now. I went to Kamatipura in Mumbai, where at the time there were 100,000 sex workers, and I moved and talked to them, and this other living conditions myself, and I can tell you they were abominable. They were substandard, subhuman, I would say. And in Mumbai Municipal Corporation, that was like a black spot, which didn't exist, because many of them didn't have even a ration card. So that was the type of living conditions they had, which I saw myself. Then I went to Thailand on a visit, and I was taken to an orphanage where young children were kept who are HIV positive. And when I went and asked the governess there, she said many of these children, they live up to maybe 5 years or so. Because at that time, the treatment program was not there. The antiretrovirals were not available. And that's the first time I touched a HIV positive person. It was a 1-year-old Thai child. And that again changed my outlook. Look, in a disaster, in a calamity, in a public health problem, it's the innocent, the young, the children, the women, they are the ones who are the worst sufferers. And this child was going to die for no fault of hers. And that really moved me. And my commitment to the HIV/AIDS program got strengthened because of these two instances. And later on, of course, I met the other groups who are vulnerable, like the drug pushers. I went to Northeast, went to Manipur, and saw many of these people who inject drugs sitting in a group. And they share the same needle. So it is very easy for the HIV to spread. At some point of time in Manipur, 70% of the drug users were HIV positive. 70%. That was the situation there. Then I came to Bombay. I met Mr. Ashok Rao Kavi. He is one of the noted activists for the gay and sexual minorities. So I saw his interventions. So this is how one by one I got exposed to those groups who are vulnerable to any such problem that comes. Even in the recent COVID, I can tell you, these are the groups which were the maximum sufferers, because their benefits were not given in time, their medicines were not given in time, even the social security benefits that governments have announced have not reached them in time. So always you have to keep a keep the ball on these poor and underprivileged sections if you want to be a public health expert. Otherwise, you will just remain a theoretician only. So again, something which I wanted to flag here. The next is the importance of evidence. As I said, without evidence, you cannot drive policy. So always focus on evidence and try to generate. So you could be a good epidemiologist, a good biostatistician, good mathematical modeler, but unless you bring out the importance of those issues to the notice of the political leaders and sensitize them, they will not move. Again, I can quote an instance. We did a behavioral survey throughout the country, and we found that one of the important things that were driving the epidemic was the adult men who had money and who are mobile, so who can buy sex and then have multiple partners. And remarkably, we found that two states, Andhra Pradesh and Maharashtra, had the highest number of men who go outside the marriage for sex. But then how do we sell this information? So we again had to go to the Chief Minister of Andhra Pradesh, at the time Mr. Chandrababu Naidu, the CM. So we met him and presented the evidence, and he was shocked. I said, is this true? He said, yes. This is what the evidence says, that if you still don't give focus to the program, then you'll be missing the bus. He immediately, of course, turned it around within a period of 1 year. He put his best people in charge of the program. He himself used to monitor, because he's a computer savvy person. He used to hold regular video conferences with his collectors even at the time. So he put it on priority, and within 2 to 3 years, we have seen the epidemic declining in Andhra Pradesh. Same thing happened in Maharashtra also. So this evidence is something which is very, very important when it comes to public health. The third important feature, again, which came in the AIDS program, which I think is very important for public health, is involvement of communities and social contracting. Social contracting is a word which is not understood by many people, because when it comes to public health programs, we always think public health means public sector health. It's not. Health doesn't mean just curative health. Health also means public health. Similarly, public health also means more than public sector health. It involves communities also, the beneficiaries, people who are at the bottom rung of the social ladder. Unless you involve them, your programs will not succeed. So we developed this system of social contracting. That means government money going to a group of people who form into a community for implementing programs within their own community. So that is what a community organization means. For example, there's a group of, say, 1,000 sex workers. They want to distribute condoms and other publicity material to their members. You give them the money. Don't send again another government official there and make him sit there and do it. You have that faith in them and trust them, give them the money, and they deliver. This is something we experimented for the first time in India. And later on, I found for the first time in the region that the social contracting, we have done it in India. And then we developed community-based organizations, provided infrastructural support to them, and through them implemented a number of these programs. We tried to do it in TB program also. Around the same time, the TB, I was also looking after the TB. But somehow or the other, it didn't succeed. The TB program still remains very much a biomedical intervention. So the involvement of communities in TB program is still very, very low. And the recent example is COVID. I can speak very frankly that right from the beginning, we were trying to impress on the government that you have to bring the communities very strongly into this. It is becoming too top-down. You need to sort of decentralize, involve the communities much more. But I think it entirely remained a government program. Right up to the Anganwadi worker or the NM, they were all government functionaries. They did a great job, no doubt. I think India's response was one of the best. But involvement of the communities would have given it sustenance. Today, why are we seeing a second wave? Because people thought it's over. But if the communities are strong, then they are the very people who could have gone to the people and said, look, it's not over. Hold on. You have to continue with some of these preventive measures like use of a mask or safe distancing, etc. for some more time to come. Let the epidemic be over. But that communication is lacking in the present case. So involvement of communities is very important when it comes to a public health program. The other thing is treatment, which comes at the end of the chain. Now, in case of HIV, unlike COVID, once you are infected, it is like a one-way ticket. There is no cure. Even now, there is no cure to AIDS, and there is no vaccine. In case of COVID, within 1 year we have vaccine. I think most of us are going to get vaccinated very soon. But the AIDS patients are still waiting after 30, 40 years rather for a vaccine. It's not happening. So treatment only means antiretrovirals. There are certain drugs which are given to them, which keeps them healthy, but the virus is still in their bodies, and they have to live it lifelong in their bodies. That's called antiretroviral treatment. But at that time, even that was not available because the drugs were very costly. They were unaffordable, and they were not made in India. And the average cost of treatment was something like $10,000 per year, which even a rich man cannot afford probably in India at the time. But luckily for us, we have a pharmaceutical industry in the country, which I think really came to the rescue. And it was Cipla, one of the major pharmaceutical companies, which announced reduction of the price of antiretrovirals by several times. The cost became so less, it is almost amounting to 1 rupee a day, something like 400 rupees per year. So from $10,000, the price came down to 400 rupees a year. So that really shook the entire pharmaceutical world. They all found fault with Cipla. They called him a pirate and everything. But ultimately, even the US program started buying drugs from Cipla at some point of time because it was cheaper and affordable. So making drugs affordable at a cheaper rate to people, and even free of cost to the underprivileged sections, is very, very important in public health programs. And we did it. In 2003, when the community was very upset, why India is still not having this antiretroviral program? People are dying. So at the time, the minister was Sushma Swaraj. Once again, I'm bringing the leader into the focus. She said whether bank gives money or not, because the program was World Bank funded. Almost 70% of the money was coming from the World Bank at the time. Now, of course, it is different. Most of the money is spent by the government. So World Bank said, no, we have no money for giving for antiretrovirals. So what do we do? And we didn't have adequate budget provision. But she said, I don't care. I am going to announce that we are going to introduce antiretroviral treatment to HIV positive people from 1st January onwards 2004. So she went and made an announcement. And she turned to me and said, now it is up to you. How do you implement it? So we took the responsibility, and then that's how the entire treatment program started. Today, almost about 1.4 to 1.5 million HIV positive people get treatment. It is one of the success stories, one of the best programs we have anywhere in the world. So again, because of trust from the leadership and the leadership given by people at the helm of affairs, we have been able to do this. So again, I wanted to sort of mention that to you. The other issue is legal environment. Now you find that many times these populations who have to be reached the benefits, public health benefits, they are either criminalized or they are harassed by the law enforcers who are at the field, like the police and the law enforcement machinery. And that is common to all the HIV/AIDS programs, because all the risk groups, so-called risk groups who are vulnerable to HIV, they are some or the other criminalized. The sex workers are criminalized. Same thing with drug users. It's a major offense and they can be in jail. They can be hanged also. I mean, that is the type of very strict legal provisions you have. And in the case of the gay population also, till recently, that section 377 of the Indian Penal Code criminalized same-sex behavior. But then improving the legal environment was an important duty for us. We started. It is not that easy unlike the other prevention and treatment programs, because you have to work with parliamentarians, you have to work with the ministers, you have to work with political leaders. But slowly but surely, we have been able to generate a type of environment within the country where people from the mainstream society, like film directors, like actors, like writers, intelligentsia, they all said, why are you criminalizing these populations? So we have been able to bring a good amount of public opinion in favor of decriminalizing some of these professions. And I think we could succeed in the case of MSM, the men who have sex with men, because Section 377 finally has been struck down by the Supreme Court 3-4 years back, so which is a major victory. So social legislations and change of law both in the books as well as on the streets. That is important. It is not just enough if you make a change in the act and leave it at that. You have to see that it is enforced. That is what we call law on the streets. So law on the books and law on the streets both need to be changed if really you want to reach public health benefits to people. So many of these are unfinished agenda in our country. And as public health professionals, I think you need to sit, if you are really, if you are committed, you have to take these things forward and try to do this. Of course, as I said, political support was very, very essential. And in case of major programs, you also need a lot of technical help, which today, of course, we had in the country. We have very good public health professionals available in the country. But in the 90s, when I was in NACO, we could count the number of public health people on fingertips, very few. And then they were so busy in their own professions, they are heading institutes and all that. So that's how the entire issue of promoting public health and promoting public health education and research, that came to my mind. When I joined the health minister as secretary, that is in 2002, I was there in NACO for 5 years. Then 2002, I moved as secretary health. So I thought we must definitely try to create a mechanism by which public health is promoted in this country. And the first and foremost thing we had to do was with the policy environment. Because we need to have a policy. Otherwise, how do we sell it to people? Suddenly, you can't bring a reform out of nowhere. So we had to look at the national health policy, as I said, which was 1983 vintage. So we worked on that. So in 2002, for the first time, after so many years, nearly 20 years or so, a new national health policy came up, and also a new AIDS control policy also. That's also important. There we mentioned that public health has to be given priority, and also primary health care has to be given at least 60% of the budgetary support by the government. These were two very important policy directives that came in the national health policy. And we also said public health is not something which can be restricted only to doctors, medical doctors, that means MBBS doctors. Because public health is an area which requires more than technical expertise, it requires certain social orientation. And anybody who has that orientation should be free to come and pursue a career in public health. There was definitely initially some doubts and opposition from the Indian Medical Association, but we could talk to them. They understood the importance of this. Because in US and in Europe, in many countries, if you look at the people who pursue the career of public health, not all of them are medical doctors. There are many who come from different fields. Some of them may be doing a master's in natural sciences, something else. I know a physicist who is one of the top public health experts in UK today, Dr. Richard White. You know, I was surprised. He is a physicist like me, but he later on moved to public health and then he became a researcher. He's a great modeler and wrote a book on mathematical modeling of communicable diseases. So that was the spirit in which this was taken, and public health was open at the time to any graduate, whether it's a dental graduate, you could be a nursing graduate, you could be botany, zoology, any of those professions you come from, you can do a public health degree. Today, in fact, in many of the public health schools, you will find people, at least quite a few, have come from the non-MBBS category of public health professionals. So, but then how do we promote it? In 2002, we hardly had 2 or 3 schools of public health in this country. But then we also thought the government control over such educational institution also should not be there. We should have it as autonomous institutions that only promotes, I think, research, promotes public health education. Government can be involved, but as a partner, not as as the deciding factor. So we developed a model which is something like a public-private partnership, where government will participate, health ministry will participate, but the chair of that management board has to be from outside the government. It took me some time to convince the government, but ultimately they saw the point. Then we had this model of the PPP, public-private partnership, as an autonomous society. So it was constituted. By the time I was about to leave the health ministry in 2004, so the Public Health Foundation of India, about which Dr. Jodhpur talked to you, came into existence in 2005-2006 as a registered society. That was one of the major public health initiatives in this country. And in the next 20 years, you will see a sea change in the public health scenario. Today, you have something like more than 30 and odd public health schools. And PHFI itself runs about 5 schools. And there are many other universities which have affiliated public health schools, institutes of public health. So that is the big change that has come with the national health policy. So the policy directive and policy environment is so important to drive any program. So here public health programs have been driven by that policy initiative. And in 2017 national health policy, that was further magnified, further I would say that elaborated, and government went to the extent of saying that there should be a dedicated band of public health professionals in each state government. Each state government. It's not that you just have a director of health services who is basically a clinician and all his other people who are in the organizations are clinicians only. You need to have a dedicated band of public health professionals to run public health programs. For example, if you have a national TB program or a national malaria program, you have positions like a district malaria officer. He should be a public health professional. Why should you bring an expert in another field and make him the district malaria officer where he is not happy, neither his expertise in that particular field is being applied there. So this is how I think we have to make a case for a dedicated group of public health professionals who have the MPH degree or at least a postgraduate diploma to man or to run programs of public health like control of diseases. Even the national health mission that you have today, at the district level, you have people looking after the mission. And essentially, they should be public health specialists because they look after reproductive health, they look after child health, they look after management of the programs, they look after monitoring and evaluation. These are not clinical occupations. So they are better done by a public health person than by a person who has just clinical experience, who has been brought there accidentally. So that's how the entire scenario has changed. I think today there is a greater realization, both in Government of India as well as in the state governments, that yes, public health is important. But again, we keep forgetting these things. I think after the AIDS epidemic was controlled a bit by 2010 or so, everybody thought we have won the war, so we went back. And until the COVID epidemic again came and woke us up that no, it's not over. Public health has to be the priority. We have more or less relegated everything to the background in the last 10 years. But COVID-19 has shaken people out of complacency. I would say that if we don't learn the lessons even now, if we don't give public health priority even now, health in general, I would say, even public health, then we are losing, it is a lost cause. Because this sort of a lesson is learned once in a century. The last was the Spanish flu in 1918. So now we have the COVID epidemic, which I think told us that, look, don't neglect health. Give it the topmost priority, both the preventive as well as the curative part of health. In fact, the COVID has demonstrated how unprepared a country can be, not just India, any country could be, to a major epidemic like COVID. So the preparedness, the disaster preparedness, and the strength of your public health infrastructure is extremely important. During normal times, yes, you provide normal work, but when there is an emergency, these institutions have to be geared up. Imagine the situation where we didn't have even facial masks in this country. People who could make masks. It took us 3 months. But of course, our private sector has shown the resilience. And today we are exporting masks to other countries. Same thing with ventilators. Same thing with oxygen. All these are basic things which have to be in readiness in a country where 50% of the population are poor and vulnerable. So that is a lesson I think COVID has taught us, and we hope at least our policymakers and our administrators keep that in mind and spend adequate amount on health. Because even today in India, if you look, we spend just 1.2% of our gross national product, gross domestic product, GDP as you call, gross domestic product on health. 1.2, one of the lowest in the world. Whereas any developed country, they spend up to at least 7 to 8% of their GDP on health. We all think US is a capitalist country and there's no public health there. There is huge amount of public health expenditure that US incurs. 11 to 12% of the GDP of US goes into health. And much of it, of course, for preventive as well as curative health. It goes. So that there is a lesson for us. We need to invest more in public health. We need to invest more into preventive and promotional health and not just building more hospitals and more healthcare institutions. That means you allow a person to fall sick and then later on try to treat him or her. That is not a sustainable practice, not a sustainable policy. You need to drive prevention much more than curative health. Until the Prime Minister talked about Swachh Bharat, we never thought public hygiene is very important in this country. Cleanliness and public hygiene. It was there. This problem was there all along. Why the TB is so rampant in this country is mainly because of the habit of spitting in public. So some of these behavioral changes which need to come, I think, are through public health programs. And their public memory is always very short. Once the problem is over, people are back into their normal behavior. But that's where I think the community has to come in. The public health people have to come in, keep on warning the people. Don't forget the messages. Don't forget the lessons that you have learned. And then, don't forget the message that you have learned. And you have to sort of see that, those are actually, that becomes the new normal. That becomes the new normal for you. If you go to any of the Southeast Asian countries, you'll find when a person gets cold, immediately they'll put a mask. That is a habit which they have acquired over a period of time. So today it helped them because the spread of COVID in those countries is much less and the mortality is much less, mainly because of this one single habit that they have of covering their nose and mouth with a mask. So simple lessons that we need to learn. Now, going with my journey, I would say the next thing that happened was I moved to Bangkok, as Dr. Jodhpur said. I joined UNAIDS. It is a UN organization. And of course, I learned a lot there. But whatever lessons I learned in India, I could apply in those countries also, in the Asia Pacific countries also, in good measure. And I actually promoted 2 independent commissions on HIV, which brought out the economic impact of AIDS, which was not there earlier. So that again showed that the impact that AIDS can have on the households, it have on the families, etc., even though the GDP was not that much affected in our area. Then finally, I moved as the special envoy of the Secretary General. I was a witness to that historic session in New York in 2015, where the Sustainable Development Goals were adopted. It was a great occasion where you had President Obama, Prime Minister Modi, and most of the heads of the states and heads of the government addressed. And then it was a unanimous decision of the world to have those SDGs. But 5 years down the line, where are we in terms of implementation? I think it is a collective failure that by 2020, many of those decisions, many of those targets which were set up in the 2015 declaration have not been met. Whether it is control of diseases, whether it is universal health care, any of these things. Because we thought, we went and signed something and we came back and business as usual. So again, something which I think as public health professionals, we need to keep on reminding the government, look, you made a promise, don't break this promise. It is important to sort of keep on bringing back public health issues to public memory. So a message which I thought I will give you. Finally, before winding up, I would like to say, what is it that for a public health, what makes a good public health professional? I think apart from your brilliance, your academic excellence, you need to have that commitment to the society. Many of us, I think we all come from middle class and poorer backgrounds. And today we are where we are because of our parents, because of the people who supported us. So we need to look back. What is it that we are going back to the society as professionals? If you don't have that habit of looking back at your moorings and thinking of doing something for those people whom you are left behind, you cannot be a good public health professional. That is the single acid test, I would say, for a good public health person. You should have that fire in your belly. You should be an activist yourself. Every public health professional is an activist. That's how I feel. And you should be willing to wave the flag when the occasion demands. When you come out and say that, look, what is being done is wrong, so it has to be corrected. So you need to have that urge to come out and speak out in favor of the poor people, in favor of the common good, public good. I think that's what makes a good public health professional, not just epidemiology or biostatistics or modeling or other things. That is important. That makes you a good professional. But you can become a good activist only if you have those qualities in you. So I wish many of you who are aspiring for a career in public health look at this journey of mine. And I try to, as Dr. Jodpe has said, I have tried to record it in a book, which is available. If any of you are interested, you can read it. I mean, it's not the same path everybody need to tread, but there are lessons that you learn. But basically, you develop a positive frame of mind because you can't be having successes all the time. There will be failures. But whenever you have a success, small success, try to celebrate. Celebrate doesn't mean go and have a party. Try to recognize the occasion. Try to see that you build on that to the next milestone. So that's what is celebrating small victories is all about. So I wish all of you well, and I wish to see you, many of you, as great public health professionals. And once again, I want to thank Dr. Jodpe, Dr. Khane, and all of you who have made this interaction possible. Thank you very much.
Thank you, sir. Over to Professor Rajane.
Thank you so much, sir, for sharing your inspiring journey. And you very rightly bring up some very important issues in public health, which needs to be addressed, like leadership issues, good quality evidence, then community engagement and social contracting. Then you also talk of access to care and treatment, and finally conducive legal and policy environment. And we really feel this is an important dimensions for any public health intervention program. May I request participants, if you have any comments or questions, kindly post in chat. We will moderate your questions. So with your kind permission, can we take some questions?
Yeah, sure.
Yeah. The first question in chat was put by Dr. Pranab Chatterjee. He seeks your opinion regarding cadre of Indian Public Health Service like IS. And do you feel like COVID pandemic will make this possible in near future?
COVID pandemic will go in 2 years. I think 2022, probably you will see the back of the pandemic. This is like another flu. But only thing is, I think, like in US, we have to develop the habit of taking flu shots every year, COVID shots, because this is not going to give you immunity for lifelong, because every year probably they will tell you later on, maybe every year you have to visit the doctor and take a vaccine. But otherwise, as a public health problem, as a public health challenge, I think it will be over. But its impact on the economy is something I think which is going to last. I mean, that's something, we are not economists. We don't know how we can't advise the government how to revive the economy. But so far as the societies and the communities are concerned, who lost their jobs, who lost their employment, who lost their livelihoods, I think there has to be concerted effort to see that they are put back on the rail. Otherwise, they will be continuing below the poverty line for a long time to come. We have lost millions of people who have slipped into the below the poverty line over the last 1 year. So unless we really do something proactive for them, both through government action as well as through civil society action, the impact of COVID will last long. COVID may not last, but the impact of COVID will last.
Thank you so much, sir. I have two questions sent on by people who are watching the YouTube live of these sessions. They are related questions. The first one is, Because the first pandemic, flu pandemic, we know about 1918, but then in last 3 decades, we have seen this pandemic occurring very frequently. Very frequently. Every decade, we are seeing some the outbreak of disease. So the participants is asking how to develop a resilient public health system, how to improve the resilience public health system, and related question to this is what kind of leadership is needed in public health to address these emerging public health issues in near future?
I think that is a good question because this resilience is what is most important. Just like an army is kept in readiness during peace times, your public health infrastructure also has to be kept ready all the time. And then that has to happen at the lowest possible level, which is the primary healthcare level. And if you look at the state of our primary healthcare, I don't think we can talk very proudly about it. Even after so many decades of independence, our primary healthcare infrastructure is still very weak. If you look at COVID epidemic itself, how many of these people have been treated at a primary health center? Practically none. Everybody had to rush to a hospital at the district or at the subdivision or a nursing home and go for treatment. The primary health centers were just not equipped. They don't have oxygen, they don't have beds, they have no ventilators. How can you expect a public health response from an institution which has nothing? So I think the main emphasis has to be to strengthen the public health infrastructure at the primary health center level, at the lowest possible level, the level that is nearest to the people. The new concept of wellness centers, which government has introduced in the last policy, I think now the thousands of them are coming up. I don't know how they're going to perform. That's in principle is a good idea because that's where you are given the comprehensive health care, both preventive and treatment in a particular center, which is well equipped, at least on paper. If we can make them function effectively, I think that will be first major breakthrough to improve the public health infrastructure at the primary level. The policy says 70% of your investment in health has to go to the primary health care. Today, if you look at it, it is not even half of it. So you need to bring a radical change there. I think that is the most important part.
Yeah, thank you, sir. So throughout your career in HIV/AIDS, you talk of vulnerable population, and you touched that aspect in today's session as well. But if you look at recent COVID, actually it has uncovered the disparity and inequity across the globe, not just in developing countries, but in developed countries as well. What do you think? Where does Indian public health system stands today in addressing those disparities and inequities, or what needs to be the future so that such disparities and inequity should not, should be minimized in future?
Actually, in any health policy, equity is the most important thing, which has to guide our response for anything. And that is because that is the most neglected part. Actually, we create facilities without bothering about how do people access them. So, as you said rightly, the COVID-19 has exposed these inequalities much more, but it was getting repeatedly exposed. Not that the first time we discovered that an epidemic, impacts people of the lower rung of the society disproportionately. It happened in malaria, it happened in TB, it happened in HIV, and even later on when SARS came in, when you have other periodical visits of the epidemics that we have like dengue, etc., we always find the poor and the vulnerable are the ones who are affected more. But we are not able to really find out a way to reach them the quickest possible time and also to sensitize them, to see that they own the program. Today we look at them as beneficiaries. We are going them with something to offer. We offer them, we come back. And after that, there's no relation between us. But if you can form local communities, if they are the ones who own the program, and you give the money, have faith in them, see that the community-based response is given priority, then I think many of these things can last long. Even in COVID, if you can make the people realize that many of these interventions you have to carry even after COVID comes under control, then probably we wouldn't have come to this second epidemic. And that happened not only in India, in many countries. So in healthcare, we always look at the people as beneficiaries and we, they type of relationship. But if we can develop meaningful involvement of the communities in programs, which again happened in the case of HIV, I would say. One very important thing that happened there also, they owned the program and we gave the money and they implemented the program. Even testing, there is community-based testing. Why couldn't we introduce community-based testing in COVID? I don't understand. In fact, I told so many times that give the money, give the testing kits to the communities. They'll be able to test in their own area much better than what you are doing. But somehow or the other, it didn't happen. So I think that's the real difference, which is important when it comes to addressing inequalities and inequities. And I think, and it should happen not only in healthcare. Inequalities are an endemic in a society in many ways, in education, in nutrition, in drinking water supply, in roads, in any issue. Inequalities are unfortunately the most important factor that is dragging the societies down in many countries. In fact, the recently announced AIDS control strategy, 5-year strategy of UNAIDS, it was approved yesterday only. It talks about addressing inequalities as the most important thing to address AIDS, which is good because you have to keep focus on inequalities for any social sector program, including health. Thank you. You are on mute, I think.
Abhay, you are muted.
Yes, sorry, sir. We can take a couple of more questions. Dr. Amey is asking, what is a key to addressing bureaucrats?
Advocating with bureaucrats. Yeah, I think very difficult question. You're putting it to a bureaucrat. So I also struggle, how to advocate to a bureaucrat because now I'm outside the system. Sometimes I find, it's difficult to interact because bureaucracy is a different type of, animal because bureaucracy cannot be typecast. It's not just one type. You have extremely sensitive, very intelligent people who came into the service because it can get you the best brains from the country. You are IIT graduates, your MBBS graduates, your graduates from All India Medical Sciences, All India Institute of Medical Sciences who have joined IAS. That means it could attract the best talent from the country. There's no doubt about it. But when it comes to providing service and interacting with the community, somewhere things go wrong. For the first 10, 15 years that they work in the field, they acquire a lot of knowledge, a lot of expertise, and you find many of them excel. In fact, in COVID itself, you have seen the experience of many district magistrates, even subdivisional magistrates who have put innovative programs where people like them. They are like heroes in their own communities. But after that, I think after the first 15, 20 years, they somehow get cut off with the reality. When they join the secretariat, they come to Delhi, join Government of India. That is the time when the challenge comes in. How do you keep that contact? Some people do. They go visit the programs and then keep that field, touch with the field. But some people just become desk-oriented. So it's very tough to interact with them. But let me tell you, if you are from your side open and place your cards on the table, I think a good bureaucrat would understand your problem. I mean, to be fair, I can't say that for everyone, but at least in the majority of them. But even the bureaucrats, the type of people they have to work with are 90% of political leaders, MLAs and MPs and ministers. The type of class which they interact, they develop a type of conceit. They think that the society is all like that. That's not the case, unfortunately. There are people who would like to come and meet you, tell their problems with you, and then you have to look at them. You can't be sarcastic. You have to be open and then try to understand their problems. So yeah, I mean, it is a difficult thing. I wish I could give you a straight answer how to interact with a bureaucrat, but it is a very complex interpersonal behavior. Thank you.
Yeah, thank you, sir. There's a question by Jitesh, but I think you have already answered this through your journey. Like he was asking, what are the approaches a dedicated public health person should incorporate? And I think your journey very well uncovers those approaches, what we should look for. And I think there are a few more questions, but we are running short of time. So we really thank you for taking your time and sharing your inspiring and encouraging journey, which which I think will definitely motivate a lot of young public health professionals in this country. Zorbir sir, would you like to conclude
Sure.
the session? Yeah.
Thank you, sir. Thank you, Dr. Gaidane. Sir, it was always inspiring to listen to you and the motivational stories that you brought us. I'm sure this interaction with our young professionals would be useful for them in their career. And certainly, as a learnings from your own journey, you have highlighted some of the important and critical issues in the context of public health and leadership in public health. And those will be very helpful to them. So thank you so much, sir, for your participation. And once again, I would request all the participants who have joined to read this book. And because I'm really actually inspired by this book. I finished it, I think, last month or so because I had to write a book review of this. But this is very inspiring story. Sir has mentioned and narrated some of the issues, but I think I would request you to go through this book. This could be a textbook for the public health professionals, I would say, and so much of a learning from this book. And so, with that remark, sir, we are grateful to you and thank you. Abhishek also, I think, joined from the organizer's point of view. Abhishek, you would like to say something before we close?
I'll only say that
Yeah.
it was very insightful to be able to listen to sir, and I'll personally buy that copy of that book and see and read it. So it has been really very insightful to listen to sir.
Sure.
Thank you very much. Thank you all. And I also enjoyed interacting with you. I wish we could have met personally, but even this is good. But maybe someday when COVID goes off and gives us an opportunity, we'll have some occasion to meet personally, and some of you at least, if not all of you. And thank you very much once again for giving me this opportunity.
Thank you, sir.